So we're here to talk about value-based payment and behavioral health care. I'd like to just kind of get a sense of who's in the room. So how many folks in the room are mental health or substance use providers? Okay, so most, okay, good. Because that was the audience we were thinking we were going to get, but I was a little worried we were going to get a whole audience of folks who aren't in our world. So the presentation we've pulled together today is mostly describing VBP, going into a bit more depth than Courtney and Greg did this morning. We're going to talk about some of the levels, explain a little bit of what is level 0 and what is level 3 and what might that in some way mean to you as a behavioral health provider. We are here for an hour and a half, so we have 90 minutes. We have slides that will cover 90 minutes. The presentation will be much more useful and robust if folks ask questions. So I strongly encourage you to make this as much of a dialogue as possible. I think one of the things, and you know, Greg alludes to this, but he's a government official, so he can't quite say it as closely out loud as I can say. Nobody knows exactly how all of this is going to play out yet. And I don't think anybody who prognosticates or tries to sell you something and says, VBP is going to do this, 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 and this, and it's going to look like this 5 years from now, has any idea what's going to happen. So what we're going to talk today is a little bit some granular details about what the state has already said, some places to start to look when we start to talk about data metrics. We're going to talk about the BHCC process a lot, not a lot, but a bit at the end. Question, how many folks are involved at a owner level or network level with a BHCC? Okay. I call network and owner, it's the same basic ballpark, and then there's affiliates. We're going to talk about that a little bit, where that is in the process, because one of the questions every time I talk to a PPS, they say, what's that BHCC thing that's going on? We hear about it, people keep raising it with us, we have no idea. So we put some of those slides in as well, and we're glad to get into as much or as little detail as possible. I think our hope is when you leave here today, you've got a little bit more grounding in what VBP is, some potentials of how that's going to impact behavioral health, and also some things to go home thinking about in terms of structures and that kind of stuff. I will also say that if you are not one of the people who raised your hand when I said you work in behavioral health, and you're from primary care, and you came to learn about what role behavioral health is going to have in primary care and those kinds of things, also feel free to raise your hand and ask those questions, and we'll do our best shot to kind of answer some of that to the best that we kind of know. You'll notice that in pretty much every sentence that comes out of Meg and I's mouth today, there will be a bit of hedging. Because again, no one's figured this out completely yet, and I just think that's important. Because it's important from a strategic perspective as you start to think through the steps you're going to take as an organization. But it's also important in the conversations you're having with government or PPSs or managed care, is that they're trying to figure all this out too. And so when you walk out of a conversation being like, wait, I don't seem to understand all of that, it's not because the person on the other side of the table necessarily had it figured out. They're trying to learn from you as much as you're trying to learn from them. And I just think that's an important perspective to have as you go through this, because I don't think anybody has all the answers yet. At least I haven't met them yet, and that goes up to Greg and others as well. So we're going to talk a little bit about the intersection between DSRIP and VBP, because I think that's often unclear and a little confusing. We'll say some of the same things very briefly that got said upstairs this morning. We're going to talk about some of the opportunities and value for behavioral health providers in VBP, and we're also going to talk to you a little bit about the quality measures that are in DSRIP already that apply to behavioral health, because if I had to say the single most often asked question that we get is, what should I be measuring? And my answer is usually somewhere around, yeah, we don't know yet. But these are some good things to start with, and we'll also give you some thoughts on kind of some of the things we're seeing and some of the things that other providers are doing. So, DSRIP VBP levels for behavioral health provider, quality measures, and then risk and gain sharing. And we may do, some of this may move around just depending on how much granularity we get into some of the slides at the beginning. So again, I'm going to pass this on to Meg for a while. Feel free to raise your hand, ask questions. It's not a big room, as always. I have to make the comment that, as always, behavioral health is in the basement, which is fine. It's a lovely room. They don't have a window upstairs either, so it's okay. But yeah, so I'm going to pass it on to Meg, and she's going to dive in.
So as Dr. Cleek said, my name is Meaghan Baier. I'm the Assistant Director for Strategic Operations at the McSilver Institute. We are a poverty institute dedicated to researching poverty policy and really looking at the rapid translation of research into programs on the ground, policy analysis. We have a large institute of about 40 to 50 staff members working on a variety of different projects. Andy and I work together very closely on all the projects related to healthcare reform. And in particular, we work very closely on our work with the Managed Care and Technical Assistance Center. So really the Managed Care Technical Assistance Center and the Community Technical Assistance Center is what we find ourselves traveling all around New York State for, meeting with different providers, managed care organizations, state partners, really making sure that the technical assistance that we're pulling together is timely, is relevant, impacts the work that is being done, and that the tools that we pull together are actually helpful. So is anyone I'm just gonna quickly go off script for a moment, but is anyone familiar with our Matrix tool? That happens to be one of our most popular tools. Okay, so this tool is actually something we pulled together per provider request. It contains all of the contact information for every single managed care organization that's active in New York State. So we, over the course of a year, worked with every single managed care organization to have every single contact that could be relevant to behavioral health providers on our website. So if you visit our website, it's under one of our tools. We've also heard from our managed care partners that it's very helpful to them and also helpful to our state partners. So it's a one-stop location with a lot of relevant information that providers and managed care organizations and state partners can all visit. So that's kind of one example of the work that we do that kind of highlights what this slide is about. So in order to make sure that our work is all culturally and contextually appropriate, our model for doing this work is really a collaborative partnership model. We bring everyone to the table to make sure that everyone's insight is really feeding the process and our guidance in terms of our final product, whatever we create, whether it's a training, whether it's a tool, whether it's a one-pager, a webinar. We want to make sure everything we're doing is relevant to the populations that we're serving. So that's kind of our model and how we do this work. All right. So, you know who Dr. Cleek and I are. We're going to now jump into some of the content today. And we're going to take another little step back because I'm sure everyone in this room is pretty familiar with DSRIP. So I'm not going to bore you with the ins and outs of DSRIP, but in order to really get a sense of where behavioral health fits in value-based payment, it's important to kind of understand the context of how value-based payment fits with DSRIP. So just general broad strokes with DSRIP. We all understand that it's a huge systems transformation initiative, right? It's all about the delivery system reform incentive payment. And really this is looking at reducing avoidable ER and inpatient hospital usage, right? That's the core component. Another major component of DSRIP is this community level collaborations. So it's important for physical health providers, for behavioral health providers, for community-based organizations to be working together and forming these networks to really improve the care of individuals that are served, okay? The other main piece of DSRIP, of course, as we know, is to achieve this 25% reduction in avoidable hospital use, okay? And also just to really harp on the fact that safety net providers are going to be required to collaborate. So you'll notice throughout this presentation and when we talk about value-based payment, the importance of collaboration across all providers, whether it be community-based organizations, physical health providers, or behavioral health. It's a core component of DSRIP. Okay, so how does DSRIP and value-based payment fit together? Let's talk a little bit about that. So we all understand and know that by year 5, which is 2020, which is not that far away, all MCOs are going to have to employ a non-fee-for-service payment for up to 80 to 90% of their provider payments. We all understand that, right? Right? Okay. So this really is to ensure that the realized transformations that are all going on are sustainable. How many of us are familiar with other system transformation initiatives that might have gone on in years past that might not be existing today, right? So I think what's really great and what New York State totally recognizes is that they want to make sure this transformation is here for a long time and it's sustainable. We know that DSRIP, the funding is limited, right? That it ends in 2020. After 2020, things are going to look a little different, but the core components of DSRIP, reducing avoidable hospitalization and ER usage, connecting individuals to appropriate levels of care, that's going to be that's going on forward. It's not going anywhere, okay?
And I would just like to add to that, one of the questions when the transition to managed care was happening on the adult side a couple of years ago, we're getting less questions about this on the kids side now, but one of the things that happened when we did the adult transition a couple of years ago, there were a lot of people who stood up and said, is this really gonna happen? You know, should I really gear up to get ready for a big change to my system? Because, you know, the state sometimes comes out and says they're gonna do stuff and then they don't do it. And it happened. Like, you know, we kept saying, no, they seem pretty serious, like this is gonna happen. So I think this, you know, I mean, you heard Courtney say it this morning, like, you know, whether we're gonna get to 80 to 90% by 2020, I have some questions, but we're moving in this direction. You know, and about a third of the payments are already in level 2 or 3. Now, most of that is actually Health First in New York City because they're owned by the hospital systems, and so that, I don't know all the details of that, but basically they're in that arrangement, a risk arrangement already. But, you know, we have made commitments to the federal government, like we are moving in this direction. What it looks like, I don't know, but we're definitely going to move down that path. So I just, you know, the whole, you can kind of bury your head in the sand and it'll pass and you won't have to deal with it, I don't think is going to happen on this.
Right. We've since removed during our managed care transformation process, we had a slide with a bird with its head in the sand. We've removed that because you can't keep your head in the sand any longer. These changes are coming, and we need to prepare for them. So I think that's yeah. Do you have a question?
Should I hold the questions for the end?
No,
Please,
feel
keep
free.
it coming.
Okay.
Small
Yeah.
room.
Okay, so maybe you could re-educate me because I may have forgotten, but isn't it by year 5 that 90% had to be in level 1?
Level 1.
And
yes.
isn't level 1 still fee for service?
So
So if you say all non-first fee.
So yeah, so let's, and we're going to get to that in a little more depth in a second, but let's take that. So
Yeah.
so level 1 and level 2 are both primarily fee for service with add-on incentive or you know upside downside risk, and we'll go into those terms in a little more depth a little later. So yes, so it's still primarily fee for service, but it's considered value-based payment because most of your money is coming from fee for service, but you're either taking, you know, either upside risk or downside risk. And so yes, and level 3, which is where many people go in their heads when they get terrified of value-based payment, is capitation. And the vast majority of arrangements are not going to be in level 3 to begin with. And I think it's really important to understand and acknowledge that the vast majority of payments are not going to be in level 3 anytime soon. And even if they are, you as a behavioral health provider may not be engaged in that arrangement at that level. You could be in level 0, level 1, level 2, even though the arrangement above you is higher up. So I think it's a really good question.
Another thing to recognize, because I think, you know, the one constant I feel like in the healthcare field is that there's just change. It's constant. Change is the one constant that's going on these days. Is to understand that with value-based payment, there's not one size fits all for all providers. There's multiple paths towards 90% of value-based payment. So there's going to be a variety of different options that MCOs can jointly choose from as we approach value-based payment. Does that make sense? So in talking to providers, what we like to say is, as you're starting to think of value-based payment, start to think of what areas you're highly skilled in. Is there a certain area of treatment that you're working in that no one else in your geographic area provides? Think about geographically how many providers are in your area, how many PPSs. Are you in a region with multiple PPSs? How many MCOs are you in contract with? Think about all of the different elements that could go into this. Do you want to add anything to that?
Yeah, and we have a way in the office of talking about this, and you can, there's kind of 3 things that we think about, and I don't know if this will ultimately be borne out by the data or not, but at least in our heads, there's 3 kind of areas that you can fall into. You can be big, so you can be big enough that people have to deal with you because you have enough market share that people have to contract with you, right? So you can be big. You can be, I like to say, sexy, right? You can be unique. You do something that nobody else does. You work with a population that nobody else does. You're the only, and this would happen in New York City sometimes more than upstate, but you work with a particular group of individuals in a particular place who trust you and have worked with you for the last 40 years, and they're going to come to you. So nobody else can do that. So that makes you intriguing to a plan or to a PPS, right? Because you're the only people who do that. The other thing, and this applies upstate more than it does, you know, in New York City and those kinds of things, is you can also be the only person who does it, right? In some counties, you're the only provider. There's no, like, there's 14 behavioral health providers, there's 7 substance use clinics in a 3-block area. You're the only one, right? So you can either be big enough, you can be, you know, unique in some special way, or you can be the only game in town, right? Those are kind of the three areas that I would think about as you start to think where you fit into this process. If you're kind of medium-sized, you don't do anything unique, and there's lots of people on the block next to you who do the same thing, I might start having some serious conversations internally about where am I going to fit in this particular space. Does that make sense to people? So it's not like a highly, conceptually organized or whatever thing, but it does start to, at least in my own head, start to help me think through, like, who are going to be the successful parties? And if you're medium-sized and you do a bunch of stuff, you may still be really valuable. But it may be that you're really valuable with a bunch of other folks around you, which gives you enough volume to actually make this work. And if you're unique, but you don't have the ability to do data analytics and all those kinds of things, well, maybe you should be providing that unique service, but maybe you need to figure out how to get the data analytics, how to get the infrastructure that you don't have because you're unique but you're small from somewhere else, so that you can also participate in those arrangements. So those are just some of the kind of the thinking that, and we'll try to weave this in as we talk today, but some of the things that we're thinking about in terms of the roles that people will play and what will make them successful as well.
So we just thought it would be helpful to walk through this a little quickly, and then talk about the different arrangements, and then talk about some of the metrics that can go along with this. So to start with, we have level 0. It's fascinating to me that we start with level 0. And this is really fee-for-service with bonus and withhold and or withhold based on quality scores. So this, to take note, is not, there's no risk sharing. This is fee-for-service payment. And actually, New York State does not recognize this as a true value-based payment level. Level 1 is really all about, again, fee-for-service payments. This is upside risk only. So, for example, if a provider enters into a contract, and at the end of the year, they take a look at the outcomes, and there's a shared savings, the provider can take away some of those savings with them.
Shaving also very important.
Level 2 is there is both upside and downside risk. So that means, go ahead.
I just want to, so if we can talk about level 1 for a little bit, because I think it's important in level 1, because it says that there's no risk per se, right? There's only upside risk. But I think as we start to think through the kind of arrangements that you might enter into at level 1, there is potentially some risk to you as a provider, because you're going to sign an arrangement where there's the opportunity for you to share in savings based on cost and quality metrics at the end of the year. You may choose to invest some money in either staff time or infrastructure in anticipation of achieving some savings of which you're going to share in. If you make those investments and those savings aren't realized, you are losing money on those investments, right? So there is potentially some risk for you. It's just not that you're going to have to write a check to a plan or a PPS or somebody else. Does that make sense to folks? Okay, so because I just think it's a common misconception, there's no risk. There is potentially some risk, and actually in order to be successful in level 1, you probably do need to make some investments in staff time or data analytics or those kinds of things. So you just, I think it's just an important distinction to just kind of remember as we go through that.
So jumping into level 2. So level 2, there's more skin in the game at this point. So there's upside and downside risk sharing. Again, this is still fee-for-service payment. But just like with any gamble, as you have more skin in the game, the cost or the risk or the reward might be higher. So with this, while there's both the upside risk and downside risk, this means at the end of the year, a provider could be rewarded with, if there's shared savings, they could receive some of the savings back. But if there's a loss, they might have to, as Andy said, write a check to the MCO that they're in contract with or the entity they're in contract with to send some of the money back if there's a loss of savings. Does that make sense? All right.
So it makes sense. Go ahead.
Now, I know you guys mentioned about sharing savings. Say, for example, you're doing a collaboration on a project. We're working with, I'm from Albany County Mental Health, and we're working with BHNNY, and we're transitioning to a 24/7 mobile crisis clinic from one we currently operate that's not 24/7. So that's an example of a collaboration. You're saying shared savings realized after a particular time period you will get to
Yeah.
sharing. But
ER usage goes down
ER
over that
usage goes
time
down,
period,
more
it saves $1 million,
hospitals.
you get half
Right.
$1 million of that. Or
Right,
whatever.
right. So, but another example of shared savings might not come from a collaboration, but might come from your target budget, where
Mhm.
based on fee-for-service payments, after you transition to a value-based payment model, either, well, in a level 1, for example, whatever your expenses end up being below your budget in the future, that's also an example of sharing in savings from that, not just a collaboration, but
So those shared savings would probably come from the total spend of, so if you were looking at
Total
total
spend.
cost of care,
Yes,
right?
correct.
And all of a sudden
Yep.
my gut, and I think commonly accepted wisdom, behavioral health spend is largely not going to go down in this process. The savings theoretically are going to come on the physical health side, and we would then share as behavioral health providers in some of that physical cost savings. But in the example you gave, let's say we used to see Meg for 20 sessions every time there was a depression episode, right? But now we only see her for 15. That reduces Meg's total spend, and then we share in that 5. The other way to do this is in a kind of bundle of care or in some kind of capitation arrangement where you get $5,000 to treat somebody, right? And then if you can do it for $3,000, you get to save the extra 2. I think that's that's one way to do it. In this arrangement, it's the total cost of care that person costs, and then you share in the savings at the end of that.
So you're thinking more reduction in cost for physical health needs than
Everything I've read and every person that I've talked to has said the savings
Sure.
are weak. So
I've
I'm
actually read that
depressed,
too,
and I have a substance use problem, and I have diabetes and cardiovascular disease, right? You deal with my depression and help me stop drinking, and therefore I'm more likely to meet my quality metrics for my diabetes care, and therefore I'm less likely to end up in the hospital and get my foot amputated. The problem for those of us who are in the behavioral health space is causation is very hard to achieve, right? To say that because I stopped drinking, I therefore went to the doctor and they found out that I had a small sore on my foot before it became infected and leading to hospitalization, and therefore I as the behavioral health provider should get a percentage of those savings. That's where this gets really complicated. So in a level 3 arrangement or in some kind of bundle, which doesn't necessarily risk adjusted bundle, or it doesn't have to necessarily be a level 3 arrangement for a particular, so an episode of care for depression or whatever, then you're getting a capitation, and therefore you're saving internally by doing a more efficient job internally, which was kind of where you were going with that question. And so either in a level 3 arrangement or in those internal savings make sense. In a level 1 or level 2 arrangement without that kind of capitation where you're paying fee for service, the savings would happen on the other side. So level 3 is what we traditionally think of as capitation. So either for total care or whatever, you're getting a PMPM or some global payment for a population of people you serve. So there's a couple things that I just want to talk about in here as well. Where you enter into any of these arrangements may be at a different level than the arrangement above you. So for many of us, we contracted either with commercial insurance or we contracted with the state for state Medicaid, or we contracted, with other entities, right? As we move into VBP, you could still contract with the state. You're still probably going to have some fee-for-service for people who have dual Medicare, Medicaid. There's still going to be some fee-for-service traditional Medicaid payments out there. There are now. There will be some going forward. You're going to have some arrangements where you contract in a level 1, 2, or 3 arrangements with a plan. But you could also have arrangements where a PPS converts itself into an IPA, and I truly believe if you stick any 3 letters together right now, you get a different payment arrangement. Like just pick 3 random letters, throw XYZ, TPQ, whatever, stick 3 letters together, you get a new payment arrangement. But you can also contract with an IPA or which is made up of hospitals or whatever. They have a level 2 or 3 arrangement up here, and they're literally contracting with you just fee for service. Maybe at level 0, maybe at level 1, but for the state's metrics, that counts as level 2 or level 3. You may or may not be getting paid at level 1, level 2, level 3. You might just be getting paid fee for service, and for you as an individual entity, that may be fine. Okay? Does that make sense to folks? Okay. So I think some of the things that are going to change for everybody is you may have more diversity in the number of contracts that you have. Okay? and it may be with different types of entities than you necessarily contract with now. But that doesn't necessarily mean for every single provider in this room that you're going to be certainly here, because very few community-based behavioral health providers have the reserves to be able to do this by themselves, certainly, right? Some of you may be here, and some of you may be here, and you may be in different arrangements with different kinds of things. So I just think it's important that the state's 80 to 90% is about the total number of contracts. It doesn't mean that every single provider in every single one of those contracts is going to be at one of those levels. Does that make sense? Okay. Helpful?
Yes.
Good. All right. Okay. I'm going to go through this real quickly. This is something you could spend, boot camp spends hours on it. So I'm not going to dive into great depth. There's 4 basic levels that they're looking at for types of VBP arrangements. One's total care for the general population, so that's a global payment where the entire capitation for the general population is taken into account. And there'll be contracts with large groups of people. The other thing just to think about as we start to have these conversations is we're going to talk a lot at the end of the presentation about partnerships. But one of the things, if you're a behavioral health provider, even if you're relatively large, and we were doing a project with one of the biggest, if not the biggest, one of the biggest outpatient behavioral health providers in the state of New York City, and they were trying to enter into a VBP arrangement with a couple plans. What happens is, when you start with this, and then you say adults, so then you go from this to this, right? Because you also work with kids. And then you say adults with serious mental illness. So then now you're down to here, right? And then you say adults with serious mental illness that are in one of the 10 plans that are in New York City. Now all of a sudden I'm here. So I went from like 15,000 clients to like 32. You can't have a VBP arrangement around for 32 clients. So start to think through those things as an institution of how much volume do you have with any particular plan and then around particular populations, because it gets tricky and you have a lot less volume as you start to winnow it down. And we have a joke in the office where we say, no matter what it is, at the end of the day, you have 100 people. Like, you go through this, you go through that, and at the end of the day, you look at one particular plan for one particular population, you have 100 people, and then God forbid you want to do it geographically, and then you have like 3 people in a particular county with a particular plan, so to be thoughtful about that, because that makes this really hard. You can't have lots of VBP arrangements around small populations because, to your point at the beginning, you're counting on the diversity in people's episodes of care to level out the costs across people, so that one person ends up in the hospital and it doesn't blow up your entire model for the whole year. So you have to have enough people, you have to have a big enough population to make that make sense. So that's one of the arguments for partnering together on things. So I just wanted to say that out loud. So the other piece is care bundles, and they're developing care bundles around a number, both in integrated primary care as well as in just as separate, around a number of conditions. Care bundles are, I don't want to say easy, but they're easy to conceptualize when you think about like a knee replacement or maternity, right? There's like a fixed amount of time, there's a very clear thing that's going to happen, and then you're going to do some stuff, and then you're going to move on. And I'm not by no means an expert in care bundles, and I'm not going to go too deep into that, but I think when we start talking about behavioral health, it gets a lot more complicated. A depression episode of care it's so hard to define a period of time, a set aside, maternity bundle. Someone gets pregnant, the pregnancy lasts 9 months, it might not last 9 months, what happens within that, there's outcomes after that, like it's pretty concrete and that kind of stuff. Depression, schizophrenia, substance use, it gets a lot more complicated. So I think on the behavioral health side, there is work being done on care bundles. It's not like a thing that I would want to jump in and say I'm an expert on, but I think it's going to be complicated as you think through the metrics and those kinds of things as we move forward. So, okay. And then there's a special needs population. For our particular group of folks, mostly it's HARP. And HARP is how many folks in the behavioral health space know about HARP? Okay, so we're all relatively, HARP is just very simply for high needs adults who have serious mental illness, serious substance use needs, and high spend in physical health as well, and they've been carved out into a plan within a plan, and they're eligible, potentially eligible for HCBS services, but not always, in health homes and all that other kind of stuff. So they are also doing special carve-outs for heart folks as well. Okay. Quality measures. So again, as I mentioned earlier, one of the questions we get all the time is, what should I be measuring? So I'm going to walk through a couple of the quality measures that have to do with DSRIP, that also apply to behavioral health, and just talk through some of the things you might want to start to think about as we go through those things, as we move forward towards VBP. OASAS has a pretty deep work group at this point looking at substance use measures that they're going to think about. I don't know if folks are familiar with that work group. OMH has started a process similar to that that's not as far along. At one point, I got an OMH document that was like 10 pages long. You know, obviously we're not going to have 10 pages of mental health measures. You know, so I think there will be quality measures. They will be complicated, but the farther you get into quality measures on anything, the more complicated it gets, because one, measuring it the same, two, attributing who's responsible for the outcomes, all that stuff is complicated. So I want to talk through the behavioral health quality measures that are associated with DSRIP as kind of an example of things that are already being measured, and if you can start to think through how to measure those for your population. So there's 29 total quality measures. We're going to talk about high performance measures, which have to do with DSRIP. So first of all, antidepressant medication management. Number of people who remain on antidepressant medication for at least 6 months. How many folks could measure that in their own programs for the clients they work with now? Okay, a couple folks. All right. If you didn't raise your hand, it's something you might want to go and look at, right? And you can get this information from your own internal electronic health record. You can get this information from Psyches. It's information that you actually, the beauty of this particular one is you can have access to this information from information that's should be in your agency. You don't have to get it from anywhere else. You don't have to rely on self-report. You have this in-house. So this is something you can gain in-house. Again, the next one is a similar vein. Antipsychotic medication adherence for people who have been diagnosed with schizophrenia. Number of people who remain on antipsychotic medication for at least 80% of their treatment period. Again, you can actually go and measure that internal to your own system without having to ask anybody else connecting to a RIO or doing that kind of stuff, right? So again, something to look at internally. Now, as we start to move down the road a little bit, this is where this gets a little more complicated. Cardiovascular monitoring, schizophrenia. So the number of people who've had an LDL-C test during the measurement year, right, who have schizophrenia. How many people ask these questions of clients that they serve in their system? Okay. How many people ask that question in a reportable field in their electronic health record? Is it in a case note, or is it something that you could run a report based on? We're working on setting that up. Right, but that's good though, right? Yeah, absolutely. So I'm going to take these two together and give an example of a way we did this in a project that actually was pretty effective, which we did. So diabetes monitor is the same. So first it's, cholesterol test, the LDL, and then they add on top of that A1C. So the standard blood test for, sugar level in your blood, A1C levels. And then the number of people who are in your system who have diabetes and schizophrenia, right? Very few of us in our world can measure that on a regular basis with the information that we have, right? In a magical world, and maybe for some people in the world, we can get that data out of a RIO or out of other things. That gets really complicated. We did a pilot project a couple years ago that was funded by New York State Health Foundation. It was providing diabetes management training to providers with behavioral health providers for consumers who had serious mental illness and diabetes. As we probably all know, the rates of serious mental illness and diabetes are twice the national average of diabetes generally. And I've actually found in working with providers, the rates are like between 20, this is just anecdotal, but the rates are like between 20 and 80% of clients in any particular program are diabetic, you know, if they have schizophrenia as well. So we had promised the New York State Health Foundation that we would tell them how many people got all 6 diabetes measures, right? Now, in writing that application, that sounded like a great idea. And then they actually gave us the grant. And we had to figure out how to actually do it, which was really complicated because we're working with behavioral health providers. You know, primary care doesn't always return your phone calls and give you that information. You got consents or whatever. We came across what we thought was a creative solution to our data problem, but actually ended up being a really good solution for the consumers. What we did is we made a card, and eventually this should be an app, but this was 10 years ago, so you know it was a card. It was a card. And on the front of the card, it said questions you should ask your doctor. And on the back of the card, it had like each of the 6 things you're supposed to do for diabetes and when you got it done. And so we gave out we printed thousands of these cards, gave them to the 20 providers who participated in this. They gave them to all their clients. And the clients would bring the card when they went to their primary care doc and say, hey, you know, here's some questions about this is the medication I'm on, does it affect my diabetes? You know, some good questions. And then like, have I had these things done and when am I supposed to get them done? And you get your eyes checked, your feet checked, there's a whole bunch of things you got to do. And then they would bring those cards back and they would put the data in the electronic medical record and then they would give it to us and we met our metrics. But what we found was, when talking to consumers afterwards, is they weren't having, first of all, they didn't know what the 6 things they were supposed to do was, right? And 2, they weren't having these conversations with their doctor before because they were going in, the doctor does what the doctor does, and you leave. So the consumers were happy about getting this information because now they had a better understanding of what was going on. And we actually called a couple of the primary care clinics because we were afraid we were going to annoy the hell out of the primary care clinics because now people are asking all sorts of questions. And the feedback we got back from the primary care docs was actually very positive because people were coming into their office with questions to ask. They had more information about their disease, so they were happy about that too. So I would be open to thinking, like, as you start to think through this, about creative ways to start to get access to this information that's beneficial for you, but also beneficial for your consumers as well. And while we are all going to shoot for the magical world where we can get this data out of our Rio or out of some other place where it's definitely accurate, I think on something like this, and the next couple measures too, starting just with self-report is okay. You have to own that. I would say it out loud when you report the data. It's self-report, like, it is what it is. But it will give you a sense and be able to allow you to have conversations with individual consumers about where they are with these things. So I would think about just starting to set up a process by which, even if it's self-report, you start getting access to this information. Okay. All right, so here's the big ones, right? It's the HEDIS scores that everybody focuses on. Follow-up after mental health inpatient, 30 days follow-up after mental health inpatient, 7 days. Substance use, rehab after 14 days. We as a state have historically done really, really badly on this. And although our numbers are trending up, as Greg would say this morning, we still don't do real great on this. The number that is in my head, and I'll blame New York City for it, so none of it would apply to any of you. The number that was in my head from a couple years ago was 18% of people who got out of inpatient detox in New York City had a follow-up within 14 days. 18%. Now, I understand that the recovery from substance use is an ongoing process, and the likelihood of relapse is pretty high when you come out of inpatient, all of that. But I can't imagine that it's helped by only 18% being seen within 2 weeks, right? So we as a system can do better than that. And so I think those are the kinds of numbers that we can track. And I know some agencies that have started to do this internally, and they do start with self-report. The Rio's supposed to help with this, and that process is slowly coming on board. But if you're a housing provider and your clients are going, you usually know when somebody goes into the hospital, after you're a housing provider and they're in your clinic. So starting to measure this data, and I will say right now, plans will do a contract with you, whether VBP or just fee for service, in a heartbeat, if you can help them with these scores. There are very few, United Healthcare doing big VBP contract with individual behavioral health provider, but I will tell you that what I do know has happened over the last several years is big insurance companies have done small contracts with individual providers to help them with these things because they get paid based on their following, they get their HEDIS scores up, they get more money.
So we have a contract with Motorola MCOs
Yeah.
specifically on this, and we've seen a significant reduction in readmissions.
Yeah.
It's unbelievable.
Yeah.
I was visiting somebody in the hospital, it's just care transitions.
Right.
Visit from the hospital, follow them around the community, make sure they're going to get to their appointment, eliminate barriers.
Absolutely.
And it's been cut in half.
Yeah. Make sure they literally, and the detox example I always had in my mind, meet them at the front door, walk them across the street, make that connection. And plans, when I used to run a provider organization, it was a consortium it was UIBH, which they mentioned in my bio, but it was a consortium of 15 providers. I used to get calls from plans, this was long before VBP, would your members be interested in doing a contract to help us with our 7-day HEDIS follow-ups? Because they get incentive payments based on that, so it's a big deal for them. What Diane said in the front row is she's from the DSRIP team, and for year 4, so year 3 it would have been I could walk you across the street and that would count. Year 4, year 5, it won't count if I walk you across the street. It has to be at least the next day.
Correct.
Okay, so if I get out today on the 5th, 6th, it's Wednesday, we're in Lake George. If I get out, sorry, we've been traveling a lot the last couple weeks. If I get out the 6th, it would count on the 7th, but it wouldn't count on the 6th.
Yeah.
Okay, all right, that makes some sense. Okay, and then we have potentially avoidable readmissions and potentially preventable ED visits. So those as well as start to think through when those things could be avoidable, and then avoidable ED visits as well. So here are all the measures. You can't read this if you're in the front row, and I'm certain you can't read it in the back row. And if you can, you should get some special kind of eye award. But they're all in our slides, and we just wanted to put them in a slide to highlight that.
And we linked them at the end. There's a
And we
resource
also
page.
link to them
Yeah.
again, resource page. All right, questions so far before we dive into some of the other stuff as well?
And just on the DSRIP side is, going back to that last slide you had with
Yes.
all the measures, those are all built into performance dashboards for the PPSs, and we load claims data every single month and with a 6-month lag into these performance dashboards that the PPSs can see that show whether it's red behind, yellow close, or green on schedule for their monthly targets and where they are for high performance. So we are seeing movement over time with district performance, but there are some, we have a small district team, but there's many other people that help run district. Some of these are challenging, like cardiovascular monitoring, schizophrenia is an area, as you
Right.
raised, could have some more people paying attention to.
Yeah, absolutely. And I think the other thing to be thoughtful about as you start to look at your own internal system, if you get to a point where you can measure some of these things, you should take that data and go have some conversations with your local PPS and your local plan. If you can measure it and what you find is not horrible, if it's horrible, that's fine. You're measuring it for the first time. Again, cardiovascular, you're not necessarily doing the visit. If you can measure it and you can add value, that's a conversation to have with your plan about this, have with the PPS about this, if you can help them meet these metrics. They're all very heavily financially incentivized to meet these metrics at this point. Yeah.
Oh, no, I just was having a thought the last time we were at Benny for a value-based payment talk. Jason Hugerson came and spoke and said that it's also important to remember that as a sort of a token of motivation to get in while you're inefficient, because
Yes.
and I thought that was an important point to make.
Yeah, I think that is a really important point to make. If you 100% you're 100% on all your measures, there's no room for improvement. The likelihood is you won't be. So don't fix everything first, I think is the global point. I think in the conversations that I have with PPSs, I think many PPSs would be very pleased, regardless of what the data said, to have serious conversations with any organization that can walk in the door and demonstrate their data. Because one of the things that I hear over and over again in talking to PPSs it's hard to have conversations around data because people don't know what their metrics are. So I think that's important. All right, some basic stuff that I want to make sure we talk about, and this gets said over and over again, but you cannot overemphasize it. First of all, be collaborative. Be collaborative. We were all raised in our little silos. I do substance use, I do mental health, I do adults, I do kids, I do primary care, and we don't talk to each other very much. And we have a whole different language too. I know when I started getting into managed care, they have a whole different set of acronyms that I didn't know. And I had, first time I heard somebody say PMPM, I was like, what? And I think now everybody in the room knows PMPM, per member, per month. But if I had said PMPM in a room 5 years ago, no one in the room would have known what that was unless they work for a plan. And so, first of all, one is be collaborative across systems. I would also think, so as I've been involved in the development of 2 IPAs, one in Long Island and one in New York City. And one of the things that I learned in that process is the amount of time people have to sit around a table and talk over and over and over again to build trust. You may have known people for a long time, but knowing people as the CEO who's down the street, who has an organization who I like, but I'm kind of competitive with, to the CEO who's now sitting across the table with me and maybe a partner in a business venture, those are very different conversations. And the trust building process of that takes a long time. And sandwiches and cookies help with that process. I strongly encourage you to buy sandwiches and cookies. Hangry is a bad way to have those meetings. And if you can't get sandwiches, definitely get cookies. When we started CBC in the city, which is it's coordinated behavioral care, it's a large, what is now an IPA in the city, started as a health home. I used to say every time you go to CBC meeting, you get a cookie. And I felt like the cookies helped. But you need to do that. The other thing is you also need to listen. Ian Schaefer, who's the Chief Behavioral Health Officer, that may not technically be his title, but he's in charge of behavioral health for Health First in the city. He talks about primary care. And he says that behavioral health providers don't listen to what primary care actually wants. They go in and tell primary care what they want from them, but they don't actually listen to what primary care says about that they want. And so listening to the other service systems around you, I think, is important. And also listening to the managed care plans. One of the things that I've learned over the last 6 or 7 years is I had never had any interaction with managed care plans other than not being able to get my own stuff paid for when I needed to. I would go to the doctor and then they wouldn't let me do, all the usual frustrations, right? But I've gotten to know all 18, there's 18 Medicaid managed care plans in the state. There's one that we're not sure really is a plan, but we won't name them out loud. But there's 18 plans in the state. And we've gotten to know and worked very closely with all 18 of them. Largely, they're reasonable people. Both the national plans, the local plans, they all have their individual wackiness that you have to deal with, just like any other company. The national plans have to think about things in terms of the impact it has on their national market. And that's important. So sometimes when you say, can you change something in your system? They say, well, no, because Utah requires that I do this. And if I change it for New York, I got to change it for you, and they have some legitimate concerns, which really shouldn't bother us, but are legitimate. But, they're reasonable people too. So understanding what they have to say as well is also important. Meeting your timelines and your reporting needs. If you say that you're going to do something for a plan, I know it sounds simple, but do it on time. Develop infrastructure. I think, so one of the things I said at the beginning, and I know Meg said and other people have said too, we don't know exactly where all this is going to go. I think the things we do know are infrastructure is going to be really, really important, and the ability to understand and manage data is going to be really important. Even if VBP went away tomorrow and we just stayed in a fee-for-service system, you're still going to have to understand your data in a way that we as a system traditionally have not done. And so there are some unique time frames through DSRIP, through the BHCC process, through all that kind of stuff to start to think through how to develop that infrastructure. And there's some money available for it, not enough, not in the right way and all that, I'll say all that. But there's going to be some money available to help build that infrastructure. So to do that, I think is going to be really helpful. The other thing to think through as you start to look through your data is when partnerships start to form, usually you get together with your friends, which makes sense, right? We've known each other for 15 years. We're going to get together in a group and we're going to form a 3-letter word payment model. You may not share clients with your friends. You might want to build a relationship with the FQHC down the street because you like the CEO of the FQHC down the street, but it may turn out that all your clients actually go to the FQHC in the other street. And so really, even though you don't like the person who runs the FQHC in the other street, that's where your clients go. And so it may make more sense to have conversations with that person and figure out how to bridge your differences than it does with the person you like. So keep that in mind too, to also start to think through some of that stuff. Okay. Performance standards. Things are going to vary across plans, and be thoughtful about that. I think in this vein, I think one of the things that we see when we talk to behavioral health providers is the same terms, and this is really important for those who are starting to form collaborations with others, the same terms mean different things to different people. So if I were to go around the room to every mental health clinic in the room or substance use clinic in the room and say, please define no-show for me, I would probably get at least 10 to 12 different answers. They would range on one extreme from, if you don't call me 48 hours before your appointment, I'm going to consider that a no-show because I'm in a rural county and people take an hour to drive to me, and so I need to know 2 days in advance in order to be able to schedule somebody in that spot, right? So I've heard that. I've also heard what was always the definition to me traditionally was 15 minutes after the hour, no one's sitting in the chair across from me, that's a no. That's how I consider somebody not showing up for their appointment, right? So if you then collect data across your multiple organizations and you're using vastly different definitions, that data is completely worthless. So if you're going to start to understand across your organizations and also within your organizations, one of the first steps to take is to very, very concretely and clearly define what each data point means. It's boring. It's not fun. It doesn't get anybody excited. But if you don't do that, everything else is garbage. Does that make sense?
Yeah.
I understand no one ever wants to do it because they always want to get to the what are the new funky data dashboards we can do, whatever. But if you don't figure out who you serve, how many people you serve, where on earth do they live? Where do the people that you work with live? How many people live in this zip code? How many people live in this county? Whatever it is, what do they look like? You know, are they men? Are they women? Are they black? Are they white? Like, who are the people we serve? And then what do you do with people? And all of this, everything I just said, is in your billing records. It's not, you don't have to collect anything new. It's in your billing system, right? Who you serve, how old they are, where they live, what their diagnosis is, what type of treatment was delivered. Those are things that you can start to measure now and don't require any additional new stuff. Because anytime you have to start collecting new information, it causes problems. So, and I'm jumping around a little bit, but one of my recommendations coming out of this is before you collect anything new, figure out how to measure what you already have and report on what you already have and make sure it's relevant not only to the CEO, but also to the clinician on the ground. The example I use all the time around service usage is I'm a kids person, so I start out working at Head Start with 0 to 5-year-olds in Poughkeepsie. That was a really fun job. It was they chase you around the yard, you know, it was a great job. I made no money, but it was a great job. So I would work with families, right? So we're doing a study in the city, working with 0 to 5. And we just got this data back that said the providers had to report on what do they do with the kids that they're working with. There was a 3-to-1 difference, individual therapy to family therapy. So 3 times more kids were being seen individually than they were with their families. I may work at NYU. I am no academic expert in the treatment of behavioral health with 0 to 5, although I do know a bit. But one thing I do know, if you're not working with a family of a 3-year-old or a 4-year-old, you're not making any changes, right? The point of intervention is with the family. I don't care if it's an evidence-based practice. I don't care what you're doing. If the family's not in the room, the kid's not going to get better. Now, there may be extenuating circumstances to see kids individually sometimes, but not 3 to 1 the other way. That doesn't require any complicated data analysis. That just requires the program director to know we have X number of kids 0 to 5. These are the number of family sessions. These are the number of individual sessions by clinician. And I, as a program director, am now going to work with my clinicians to drive that number in the right direction so it's 3 to 1 the other way, right? That's not incredibly complicated. But it could have a big impact on the quality of services you deliver, and it doesn't require you to bring in a fancy expert or a trainer or to do like a whole revolutionize the training modalities you do. So those kinds of things are thoughtful as well. The other piece of this is individual versus network stuff, and where you as an organization are going to do stuff individually versus as part of a larger group, whether it's so one of the things, I'll talk about BHCCs in a second. One of the things to be thoughtful, a BHCC is not a thing for the behavioral health folks. It's a mechanism for OMH and OASS to get money out the door. The BHCC as an entity is not an entity of any legal standing. It can be a bunch of different things, which is good because otherwise it screws up my joke because there's 4 letters in BHCCs and there's only 3 letters in payment mechanisms. So, you know, I have to keep it that way. But, okay. All right. So we've talked about this a bit. The other things I would look at also are QAR measures and HEDIS measures, the CAP stuff, and AHRQ and all those other measures as you're starting to think through other measures that are available. Okay, risk sharing bonus payment. I'm going to jump around here a little bit. I'm starting to look at okay, bonus payment, pay for performance, right? I see people 75% of the time within 24 hours of a referral. That's pay for performance. There's no risk sharing, there's nothing else. I just get a bonus payment based on that. That in New York State would be considered level 0. There we go. All right, we're good. And incentive payment. Risk gain sharing, we're really starting to think about population health, right? It's not health based on you versus you versus you versus you. It's based on a population of people. And back to the earlier point today, that population of people has to be big enough to be able to actually make some judgments based on the size of the population. Oftentimes it includes total care, but it can also include certain bundles and have carve-outs of that. It has to adjust both cost and quality. So we tried this game before in the late 80s and early 90s when we did what is now called Managed Care 1.0, right? Gave money to managed care, HMOs, and how did they make money?
Restricted care, denied care.
Right, restricting care, right? They got a pool of money for a group of people, and the best way to make money was just to deny care, right? Because there weren't necessarily quality metrics associated with that. So the way to deal with that in what we now start to call Managed Care 2.0 is to address cost. You want to look at the total cost, but you also want to look at the quality measures associated with that cost, and that's where we end up with the triple aim. Population is better off, costs are less. But you have to look at cost and quality as well. Just real quick, bonus payments or pay for performance, right? No risk, potentially small gain. Upside gain, only total care. No risk, but with the caveat that if you make investments based on money you think you're going to get later, you may be risking something. Level 2 or downside risk and upside gain. So can somebody tell me why you as a provider might be willing to enter into, I understand why a plan would want to enter into a level 2 arrangement, right? Because if the cost goes up, you write them a check. Why would you as a provider potentially want to enter into a level 2 arrangement where you're at risk for downside risk?
Because there's potential for upside.
Because you have potential, well, you have potential for upside in the level 1 too. You have greater potential for upside, right? So if I'm a plan and you're willing to take some downside risk, then I'm going to be potentially willing to give you more of a share of the savings because you're also taking some of the downside risk. So the reason to go to level 2 is because you'll get more, potentially, you'll get more of the shared savings than you would in level 1. If somebody's offering you a contract where they're going to give you the same amount of shared savings in level 1 that they would in level 2, you should not be signing that contract, right? You're taking more risk and you get no extra benefit. All right, and then capitation, obviously we talked about, it's high risk, but it also high gain. It gives you a lot more flexibility because you're not billing fee for service underneath that. All right, talk about BHCCs really quickly. So BHCCs are OMH and OASAS funding to incentivize collaboration. And the logic behind this is OMH and OASAS have given out money for certain things, HCBS, that kind of stuff in the past. You give everybody a little bit of money, but it doesn't deeply impact the system because everybody gets 50 grand and then you get spent and then it's kind of spent and it's gone. OMH and OASAS, I think, and I don't think they would argue with me saying this, believe that collaboration among behavioral health providers is going to be essential to their stability in a new transformed system. They are not taking a formal position, and I am not speaking on their behalf, but they are not taking a formal position of what that collaboration should look like. But they think that if people don't work together, they're not going to have the volume to be able to really play in this game. And so they're putting out some money, $60 million over the next 3 years, to encourage the facilitation of that collaboration. Yes?
Two questions.
Yes.
One, how do you access that funding? So how might
That's an
organizations do
excellent
that? Then I
question.
have a second question.
Okay. So there was an RFP process.
Okay.
The RFPs have gone in. BHCCs formed around the state. The letter of intent was what, like 49 or something like that? I'm imagining that less went in with the actual application than went in the 49. They are going to then choose those organizations, the BHCC's applicants, based on whether they meet certain criteria. So the criteria include the percentage of the total number of available clients in a particular geographic region, whether they have representation from both behavioral health and substance use, large providers, all that kind of, small providers, all that kind of stuff. And I actually have that on a slide, so I will use the actual slide and not just do it from memory. So they have to have a full spectrum of regionally available behavioral health programs. They have to, they can exclude things, but not intentionally. So they have to keep, unless if it doesn't exist. They can't be a single provider. The goal of this money is not to go to, Joe's clinic on the corner. The goal of the money is to go to facilitate a collaboration between Joe and Susie and Bob and Phil and Stan, or I'm losing names. I got 10 minutes left. So the goal is not to give that money to the individual providers per se, it's to facilitate this collaboration. That doesn't mean that individual providers can't get some funding out of it. So if we as a collaboration agree that we need one electronic health record, we're going to use one EHR across all 5 of our providers because we think that's going to be more efficient, it's going to facilitate clinical and financial integration, it's going to do all that kind of stuff, then we could use that money to buy an EHR that serves all of us. But we couldn't use that money to prop up our deficit and the fact that we're losing money in our clinics. Okay, so so the answer to your first question was there was an application process. Whether the BHCCs that have formed as part of that application process when the announcements are made are closed off to inviting new members to participate or not, I don't know. It'll probably vary based on who they are. But once the letters come out, or if you know who applied, I would have conversations with those organizations that are forming now. The earlier the better, to get in on that process. There's 2 levels of this. There's a network level and an affiliate level. A network I call an owner. Those are the decision makers of the BHCC. And there's an affiliate level, which is other network providers who might be part of it, but aren't owners, aren't going to necessarily share in some of the risk arrangements and stuff like that. Yes, there was a question back there, I think. No?
I had a second question.
Yes.
So I'm an administrator of a health home.
Yes.
So this to me feels so much like a health home, like the BHCC, because you're creating a network among behavioral providers in the community, but the health home is also about establishing a network of providers that are serving high-risk population that are on Medicaid.
So I'm going to speak for myself for a second, be very, very clear that I'm not in any way reflecting anyone's views but my own.
Okay.
I think this is the natural evolution of the health home. I think the health homes, so CBC, which is a thing in the city, got started as a health home. And we set that all up. One of the issues with health homes is that it put care management on the system, but it didn't provide leverage to actually make that care management be able to get anybody to do anything, right? So you established a health home, right?
Yep.
But your health home care manager can't call up the primary care office down the street and be like, hey, you need to get Joey in there, right? Because his diabetes, you have no leverage. So I think this process and DSRIP 2 is really starting to put those networks together with some teeth.
Yeah.
So health homes are going to be an essential part of this entire process. There's no way that health homes aren't. And largely, they're all the same people, right? I will speak for New York City because that's where I live. There are 10 people in behavioral health in New York City. We all walk around, you know, we go to the same meetings, we know each other. Every time there's a new thing, we all get together and do the same thing, right? Like, you look at, like, you know, when I was at UIBH, my board was the same board as the CBC board when it got founded. Like, it's all the same people. And they're all doing care management in health. So, yes, it's all the same people. Yeah.
One point of clarification for our friends at Samaritan. Is it true that hospitals can't participate in BHCCs?
So here's that's a really important question. So the funding was designed to go to community-based behavioral health, OMH and OHS agencies. Hospitals can't participate at the network level in BHCCs. They can participate and are strongly, strongly encouraged to be part of the network at the affiliate level. The goal was that, and this is partially a response to DSRIP too. A lot of the funds, and you know, there's been some public discussion of funds went to hospital systems and didn't trickle down to the behavioral health providers. And so part of this is a response to that, to build up that infrastructure to be able to have those conversations. That makes sense to everybody?
Yep.
Okay. All right, I'm going to jump ahead quickly because I'm running out of time. So network, we already went through all this. Full spectrum of services, peer-run agencies, CCBHCs, which are this new national models like an FQHC for behavioral health, community rehab providers, smaller agencies, CBOs. They should all be part of the network and the affiliate members, but hospitals, to my point earlier, can't be part of the network members. They also have to make a good faith effort to include, you know, PPSs, FQHCs, state-run agencies, primary care, and all those kinds of things. All right. This is going to be really important. These two things are important just to think through. First of all, the state has identified a weighted average of total percent of the population at like 2.5%. No BHCC that comes in under 2.5% of the total available population in a given geographic area will be funded. If I had to bet money, and again I'm speaking for myself, I think that percentage will go up over time. I think that it will be a higher percentage as we move forward, just because 2.5% is not a huge part of the population, so I think it'll go up over time. No provider can make up more than 60% of the total thing, so it can't be like, I'm the giant provider and I do 89% of the services, and then I got like 3 other people to join my BHCC, so it looks like it's a collaboration, but really it's me. So you can't do that. And they didn't want children-only BHCC, so the threshold can't be more than 51%, 50% kid services. Whole bunch of stuff. I'm going to skip through this. $60 million over 3 years, basically split, you know, half in the city, half the rest of the state. Which, if you look at the number of agencies and programs statewide, which we do because that's what we do, it splits out about like that. It's about half in New York City, half the rest of the state. So the funding will be split that way. We talked about that. The final deliverable 3 years from now is this entity, whatever the entity is, whether it's an IPA or whatever the entity ends up being, would have to either contract with an entity in a level 2 arrangement or higher. So that's contract with an entity, contract with a hospital system that's in a level 2 arrangement, or participate in a level 2 arrangement as a level 1 provider in a network. If there's no, you know, level 2 arrangement in your network area, you know, they'll make exceptions. But that's the goal. Basically, is at the end of year 3, this entity is collaborated and as part of a VBP contract. So that's the ultimate deliverable of the thing. So we stuck some additional resources in. Here's all the Medicaid redesign stuff on the website at the state. I'm sure you're all familiar with that because you're here today. Here's our MCTAC value-based payment resources. That link will be there. Our website's mctac.org. Everything we do is there. Many of you get our really lots of emails from us, I'm sure. If you don't get lots of emails from us, you can go on our website, mctac.org, and sign up to join our email list. And then you may regret that later on. But we're doing all sorts of stuff in all of these kind of spaces as well. So other questions before we wrap up? Helpful?
Yes.
All right.
Good job. That's good.